This is session number 305, Immunotherapy and Thyroid Cancer with Dr. Ann Gramza. And let me introduce Dr. Gramza. Dr. Gramza, Ann Gramza, is a medical oncologist and associate professor of medicine at Georgetown University, specializing in the treatment of head and neck cancer, thyroid cancer, and other rare and endocrine malignancies. Dr. Gramza conducts clinical trials with new targeted therapies and immunotherapy drugs. She has considerable experience in thyroid cancer clinical trials, having been previously employed at NIH, where she conducted several thyroid cancer clinical trials with novel therapeutic agents. And with that, Dr. Gramza, welcome, and we're so happy to have you.
Thank you. Thank you so much, Jean. I hope everyone, you can hear me okay. I'm Ann Gramza, as Jean mentioned, and I can't see who's attending, but I hope I know some of you, and I wish I could see you in person again. So I'm going to talk about immunotherapy and thyroid cancer. So in order to understand immunotherapy, you have to have sort of a basic understanding of our immune system and how our immune systems work to rid our bodies of foreign invaders. So things that aren't supposed to be there, like bacteria, and other viruses, infectious agents, and abnormal cancer cells. And then if it works for bacteria and viruses, why it doesn't always work for cancer. And how we have new treatments that are being developed to fix the ways that cancer outsmarts the immune system. So what is the immune system? The immune system is really the body's defense against disease-causing organisms, malfunctioning cells, and foreign particles. And there are different types of immunity. So there's the innate immune system, which is really just sort of there, laying in wait, non-specific to kill an invader. So that's a kill first, ask questions later type of immune system. And those cells are called neutrophils and macrophages. They're there ready to respond to infection, inflammation, and cancer. And it's really the first line of defense. And then there's adaptive immunity. This is the more specific and selective type of immune response. So these cells have memories and can be educated. These are B and T cells. So when you get a vaccine, you're training the cells to attack the foreign invader. So what you get is a B and T cell response from the B cells make the antibodies and the T cells go on the attack. So when you get a vaccine, that's what it's doing. It's exposing these cells to the foreign particle that if it comes in, you can attack, or at least a piece of it so that you can attack. And these cells, as I said, have memory and can recall prior exposure to stimuli, bacteria, etc. This is just a figure of the innate immune system cells and adaptive immune system cells and how they overlap. So is there an immune response to cancer? Yes, there is. And I think maybe some of you have heard of those spontaneous remissions that are sometimes seen in thyroid cancer. So, and we've heard that in other cancers. And it's not a miracle. It's the immune system, most likely, although I can't rule out miracles, but I'm saying it's probably the immune system. So can the immune system get rid of cancer? Yes, but there are also many obstacles to effective anti-tumor immunity. So normally what happens is when you have a tumor cell, or what's supposed to happen is when you have a tumor cell, it releases these little antigens. So these are little particles that are specific to that type of cancer. And because tumor cells are all the same, you expect each tumor cell in that tumor to have those antigens. And then this little guy, this antigen presenting cell, is sort of roaming around in the blood system. And it gathers, it soaks up these antigens, and then it takes this innocent, naive T cell that has never been exposed to an antigen, virgin T cell, if you will, and it activates that T cell to recognize that antigen. And so what should happen is if there's a tumor cell wandering around presenting its little antigen, like a little flag, like, hey, this is my antigen, the T cell should go after that tumor cell and eliminate it from the body. But, you know, tumors go to great lengths to evade this immune response. And there are so many different ways that cancers have figured out or sort of really evolved. I mean, they're not, you know, sentient beings, but they evolved to defeat the immune response. So one thing they can do is decrease the expression of tumor antigens on the surface. So they're like, nope, nothing to see here. I'm not going to put that antigen out because you know you can find me if I do that. They can also put proteins out that tell the immune system to stop, like a little stop sign saying, oh, I know you recognize me, but you can't attack me. I have this stop sign that you know that you have to obey. And they can also stimulate cells in the surrounding environment to make chemicals that suppress the immune response. So like almost like drugging your immune cells, like, oh no, you don't need to come get me, go to sleep now. And so that's how they promote their tumor growth and survival. So the goal of immunotherapy is to try to find strategies to liberate and sort of defeat these ways that the cancers evade the immune system. This is just a picture of what I just discussed. So normally you have the T cell that's supposed to recognize the tumor cell antigen, and it's on this little antigen holder, which is called an MHC complex. But sometimes the tumor cells don't put the antigen there, and so the T cell can't recognize it. Sometimes they have mutations in the little gene holder or the antigen holders, the MHC complex. So the antigen's just stuck inside there and the tumor cells don't put it out for the T cell to see. And as I said, sometimes they produce immunosuppressive proteins. So even though the T cell latches on, they sort of get drugged into not working against the cancer cell. And so what tumor cells really essentially do is they can slam on the brakes of our immune system. And I also told you that they put out stop signs. So this is a stop sign. This is PD-L1. This is a protein you may have heard of, and it's expressed on some tumor cells. And what happens is if PD-L1 is on the tumor cell, even if the tumor antigen is there, this is your T cell, this is your immune cell. It says, hey, I recognize you. I'm supposed to kill you. Oh, whoops, the tumor cell put up this PD-L1 protein, which is a stop sign, and tells the T cell, you know, leave me alone. And so that's one way that they block the immune response. And so how does cancer immunotherapy work? Well, the goal is to really increase the strength of the your immune system response against the tumors, not to kill the cancer cells themselves. So it stimulates activity of specific parts of the immune system and counteracts signals produced by cancer cells. And there are several different types of cancer immunotherapy, and we're not going to talk about all of them today because unfortunately in thyroid cancer, not all of them have been found to really be effective. I gave a talk about this 5 years ago, and I was looking at my slides and I was like, this study's going on, this study's going on. And unfortunately, some of the studies with the cancer antibodies and vaccines haven't really panned out quite yet. Not saying it's not going to happen, but not interesting enough to share right now. But there are these immune checkpoint modulators that we're going to talk about. Not really going to talk about immune cell therapy or immune system modulators. So immune checkpoint modulators, that's what most people think of as immunotherapy. These are the ones that are on TV that you hear about, you know, the miracle drugs, Keytruda, which is pembrolizumab, Opdivo, which is nivolumab, Yervoy. These are the ones you see, that's ipilimumab. Those are the ones you see on TV commercials. And the reason these drugs are called immune checkpoint modulators is because the immune checkpoint proteins are the brakes that we need to keep our own immune systems in control. So if you think of a checkpoint, you know, if you think of a checkpoint like sobriety checkpoint, if you will, you know, that's when someone's standing there watching to make sure that the person who's drinking and driving doesn't get through. So an immune checkpoint is a protein like PD-L1 that the normal cells will express so that immune system leaves the normal cells alone. And without them, without these immune checkpoint proteins, our immune systems would attack normal cells. And when your immune system attacks cells, that's basically autoimmunity. So for people who have diseases like rheumatoid arthritis, lupus, ankylosing spondylitis, those are autoimmune diseases where the immune system's attacking various organs and you know, joints and other things. The most common is like eczema. That's just a rash that your body makes against itself, nothing in particular. And so cancers have figured out ways to commandeer these immune checkpoints and use them to block our own immune system from killing cancer cells. I found this the other day. I really like it. It's from this website called Immuno-Oncology Time to Talk. So, you know, you could go to this website and they have good explanations of, simple explanations of how immunotherapy works against these immune checkpoints. So I know I keep saying the same thing over again in different ways, but it's a pretty complicated topic. So I really want you to try to understand or give you a good explanation. The viruses and bacteria that enter our body, normally this is the immune cell, this car, you know, just runs right over them, runs right into them. But a normal cell in your body has a stop sign. That's an immune checkpoint protein. And what cancer cells sometimes figure out how to do is hold up their own stop signs, even though they're not supposed to have them. And the immune cell has to stop and doesn't go after it. So immune checkpoint inhibitor sort of goes in the in-between and blocks that stop sign and tells you, no, go on, move ahead, kill that cancer cell. So what is an immune checkpoint modulator or checkpoint inhibitor? So like I showed you before, when this is the tumor cell, this is that little protein that sticks out and holds the antigen so that the T cell recognizes it. And normally PD-L1 protein isn't supposed to be there. This is an immune checkpoint that it's only supposed to be on normal cells, but the tumor cells express PD-L1, and then that signals the T cell not to attack. So what you can do is give drugs that fit in these little receptors. So you can give an anti-PD-1 drug or an anti-PD-L1 drug, and that will then allow the immune cell to recognize the tumor cell and kill it. Anti-PD-1 drugs, those are cemiplimab, pembrolizumab, nivolumab. Anti-PD-L1 drugs are a little less common. That would be like atezolizumab, avelumab. So all of these are what we think of as immunotherapy, and they're antibodies that block the immune checkpoint proteins to allow our own immune systems to sort of take off the brakes against the cancer cells. These are all of the immune checkpoint inhibitors. You don't really need to read this, but up here is sort of, this is a list of all of the different types of cancers. As this recently updated, I guess that was just less than 2 weeks ago on the Cancer Research Institute website. You can always go and look and, you know, explore this website about immunotherapy. You know, melanoma, lung cancer, kidney cancer, lymphoma, head and neck cancer, and then all of these other types of cancers that immunotherapy is approved for. Thyroid cancer isn't on here. But you can see here that the first one of these types of drugs was approved in 2014 for melanoma. There's another drug, ipilimumab, that was actually approved in 2011, but whoops. But this is a timeline of when the drugs were approved, and down here, just a list of the different PD and PD-L1 inhibitors that are now approved by the United States FDA. What happens if the immune system gets activated and doesn't attack the cancer cells, but attacks something normal in your body? And that's what immunotherapy side effects are. So they're not going to be the side effects that you see with chemotherapy, with normal chemotherapy. These side effects are when the immune system goes after the wrong thing, and it can be any organ in the body. It can be a pituitary gland and cause a lot of problems. Rarely, you can have brain or spinal cord problems. Sometimes patients have the immune system attack their muscles, and they can get pain or weakness in joints. Rarely attack the heart. It's called myocarditis. Basically, it's any type of itis, so that would be inflammation. So muscle problems would be myositis, heart problems would be myocarditis. Bowel problems, you can develop diarrhea, where the immune system attacks the bowels. Joint problems, that's arthritis. Skin problems, dermatitis, you can get a rash. That one is probably the most common with mild fatigue. You can have some nerve problems where it attacks the nerves and you get peripheral neuropathy, that's called neuritis. Inflamed lungs, pneumonitis. Thyroiditis, so this is pretty common, more common than these other complications other than skin, where patients' immune system attacks their own thyroid. They actually get a thyroiditis often, where they become hyperthyroid. The thyroid's overactive, and then it burns out. It's like a Hashimoto's thyroiditis or other type of thyroiditis, where it burns out and then they become underactive. Eye problems, so iritis and other eye problems. Fortunately, most of this does not occur. So serious side effects really occur in less than 5% of patients. They're often mild side effects. And if you develop side effects, there is a way to stop the immune system from attacking, and that would be steroids. So in almost all cases, if the immune system attacks, say, the lungs, then you can give steroids. Usually, if it attacks the thyroid, we still continue treating because you can't really reverse it, and you just can, and there's a medicine that you can give to easily manage it, as most of you know because you're on it, levothyroxine.
Dr. Gramza?
Sure.
We do have a question.
Sure.
Sorry for interrupting you, but
no, not at all.
To this. The question is, will a person who has been in remission for many years for ulcerative colitis not be allowed to try immunotherapy ever? He is PDTC, RAI refractory, and already uses many TKIs in the last 12 plus years.
That is a really good question. So no, yes, you can try an immunotherapy. You can give it a try. You would be at slightly higher risk of having a relapse of your ulcerative colitis. And people who had autoimmune disease like ulcerative colitis were not allowed in these clinical trials that tested immunotherapy. But if you were my patient, I would definitely give it a try, because at this point we know that we can manage your ulcerative colitis if it comes back. And if it's something that, if you're running out of options and it's one of the few cancer options remaining, it's worth a try, I think. Especially since you've been in remission for so long. Other things though, like kidney transplant, liver transplant, especially liver transplant patients, that's a little more scary. We don't see many thyroid cancer patients with organ transplants, but I do see them in head and neck cancers because being on chronic immunosuppression can give you a squamous cell cancer, not really thyroid cancer. But in those cases, it's very risky because you could result in rejection of an organ. In your situation, if you have a recurrence of your ulcerative colitis, we could put you on steroids and then get the doctors to put you back on some immunomodulatory drug that can help with the ulcerative colitis.
Thank you, doctor. If anyone
Sure.
else has questions, make sure you put them in the Q&A.
Yeah,
hopefully they
please
will be
do.
addressed.
Yeah, because that's a really good question. Then, so this is just a little summary slide. Occasional side effects, fatigue. Most of my patients, I would say, have a little fatigue for a few days after they get one of these drugs. But I've treated patients who are in their 80s on these drugs, and most of them tolerate it really well. You're just as likely to have a severe side effect when you're 25 as you are when you're 85, as opposed to regular chemo or even the TKI therapies that some of you have been on, where the possibility of a severe side effect goes up as you age. Rash, we'll see some weird rashes. Sometimes I can manage them on my own. Sometimes I have to send people to the dermatologist if they're a little more extensive. Again, we'll sometimes see diarrhea, very infrequently. You can have elevation, inflammation of the liver test. Again, you can have thyroid issues, but infrequently is inflammation of the lung and other severe toxicities, side effects. So what about for thyroid cancer? So I showed you that slide. These drugs are approved for multiple different cancers. Why not thyroid cancer? And why would we think they might work? As I mentioned, the side effects of therapy include anti-thyroid autoimmune responses. Therapy with ipilimumab, which we're not going to really talk about too much, causes about 6% risk of thyroiditis or hypothyroidism. And I would say it's probably the same with pembrolizumab as well, just based on my own personal experience. And then therapy with a combination of ipilimumab and nivolumab caused a 22% incidence of thyroiditis or hypothyroidism. And PD-L1, the protein that I've been sort of beating you over the head with in this lecture, is that protein that's expressed on tumor cells that we think, or that we know sometimes shuts down the immune response to cancer. Well, there's increased PD-L1 and PD-1 expression in some thyroid cancer tumors, particularly the anaplastic thyroid cancer and some papillary thyroid cancer, or other differentiated thyroid cancers. So we're hopeful that there is a role for immunotherapy in thyroid cancer. So I'll start with pembrolizumab. This is the drug Keytruda that you've seen on commercials, and this is a drug that targets the PD-1. So PD-1 is on the T cell, so it blocks this, so that the tumor cell can recognize. The T cell can recognize the tumor cell and kill it. And there was a study that maybe some of you have heard of, where there were 22 patients with advanced differentiated thyroid cancer, and 15 patients had papillary thyroid cancer. 7 patients had follicular thyroid cancer. And they only allowed patients who had PD-L1 on the tumors, which they can stain they can stain the tumor cells and look at it under the microscope. Briefly breaking in here, just to talk about what the different stages of a clinical trial are. So phase 1 studies look for safety. Phase 2 studies check for efficacy. Does this work in this specific tumor type? Phase 3 studies look at large populations and confirm that they work. We don't have many phase 3 studies in thyroid cancer because it's so rare, although there have been a few. And phase 4 studies are long-term. And when we talk about responses in these clinical trials, it's kind of confusing because you'll hear 9% response rate. Well, what does that mean? We use these criteria RESIST, where you, and pardon me if you've already heard this at the meeting, but you basically estimate the overall tumor burden at the baseline, and that's the way you can determine the objective response to treatment. So I will take, we'll take 5 lesions total. This is the way it works, 2 per organ. So you usually find like 1, 2 of the largest lung metastases, you go to the different organ, and then you measure the longest diameter. And so the sum of all of those longest diameters is the baseline that you're going from. And when we determine if there's a response, if there's a complete response, that means that all of the target lesions have completely disappeared. So we don't see anything. A partial response is a 30% decrease in the sum of the longest diameter of the target lesions. So if you've got only 1 target lesion and it's 10 centimeters, if it goes to what would be 6 centimeters, that's a 40% decrease. So that would be considered a partial response because it's more than 30%. Progressive disease is if you have at least a 20% increase in the sum of the longest diameter. So if you have a 10 centimeter lesion and it goes to 12 centimeters, that's a 20% increase. So that's considered progression. But what if it shrinks by 15%? What if it grows by 15%? What if it shrinks by 29%? Those are all considered stable disease. So stable disease doesn't mean necessarily that the cancer hasn't grown or that the cancer hasn't gotten smaller. It just doesn't meet one of these 2 criteria. So it's sort of everything in between. So pembrolizumab had a response rate of 9%. So that means that there were 2 partial responses. So there were patients who had the cancer shrink by less than 30%, but 2 of the patients had tumors that are overall tumor burden that got smaller by at least 30%. And both of these responses occurred, one occurred at 16 weeks and one occurred at 24 weeks. So it took a while, 4 months and 6 months to get a response. But the response durations were pretty good. At least one of them was 20 months and the other was 8 months. Not the greatest. And that sort of put the brakes on pembrolizumab in differentiated thyroid cancer, at least by itself. So then, we know that lenvatinib can really be quite effective, 65% response rate in differentiated thyroid cancer. And so what if we add pembrolizumab to lenvatinib? And this study looked at 30 patients who had radioiodine refractory differentiated thyroid cancer. Patients were started on 20 milligrams of lenvatinib and then pembrolizumab or Keytruda, which is an IV drug given every 3 weeks. Now it's also, you can get it every 6 weeks too, or you could either get it every 3 weeks or every 6 weeks. 70% of patients required lowering the dose of lenvatinib, and there was a 62% response rate. So not really any better than lenvatinib by itself. But what about pembrolizumab and lenvatinib in poorly differentiated and anaplastic thyroid cancer? This was a tiny retrospective study where investigators looked at previous patients treated with pembrolizumab and lenvatinib. They had 6 patients with anaplastic and 2 patients with poorly differentiated. The 2 patients with poorly differentiated both had partial responses. And then 4 of the 6 anaplastic patients had complete responses. So that looks really good. And the average survival, we know anaplastic thyroid cancer is very aggressive, was 18.5 months for those patients. These were all patients who didn't have a BRAF V600E mutation, by the way. And when they published this, there were 3 patients who had responses who were still alive at 40 months, 27 months, and 19 months since starting treatment. The patients who had at least a 2-year response or a complete response had either a high tumor mutation burden or PD-L1 score. And I'll talk about that tumor mutation. That means a lot of their cells had PD-L1 on them, like 90%, or at least 50%. And tumor mutation burden is how many mutations your cancer cells have. And I'll talk about that in a minute. So this led to this ATLEP study, anaplastic thyroid carcinoma, lenvatinib, pembrolizumab. So that's the ATLEP. And this enrolled patients with anaplastic thyroid cancer and poorly differentiated thyroid cancer. This data was just updated a week ago, actually less than a week ago. So that would be this past Monday. It was presented at ESMO in Europe, which is the European Society of Medical Oncology. So they had 27 anaplastic patients and 8 poorly differentiated patients. And the anaplastic thyroid cancer, 14 of 27, which is almost 52%, had a partial response, and 12 of 27, which is 44%, had stable disease. That's pretty good. 7 of 27 survived more than 2 years. Again, good. And the average overall survival was 10.5 months, which, for metastatic anaplastic thyroid cancer, unfortunately, we really haven't seen anything quite that great, except in patients with BRAF mutations who take dabrafenib and trametinib. In poorly differentiated thyroid cancer, there was a 75% response rate. And those patients, they haven't even reached average survival yet. So this appears to be a very, very active combination in BRAF negative anaplastic thyroid cancer and particularly in poorly differentiated thyroid cancer. Very exciting, hot off the presses. There's another drug like pembrolizumab called nivolumab, that's Opdivo, and ipilimumab, which is Yervoy. Ipilimumab is a CTLA-4 inhibitor, so it affects the immune system in a slightly different way. And this was tried, this combo. This combo is a lot more toxic than just these PD-1 or PD-L1 inhibitors by themselves. They had 49 thyroid cancer patients, 32 with radioiodine refractory differentiated, 7 with medullary, and 10 with anaplastic. And in differentiated, they saw a 9% response rate, which is sort of what we saw with pembrolizumab, and probably would have been the same with nivolumab alone. That was in 3 patients. These patients were Hürthle cell and poorly differentiated. Medullary, no patients responded, and anaplastic, there was a 30% response rate. So that's also pretty good. This was a tiny Japanese study that looked at nivolumab in different tumor types. There was 1 thyroid cancer patient who had a partial response, and it was actually medullary thyroid cancer. This patient had a response for more than a year to nivolumab. So that's this one right here. So possible that these drugs could work in selected patients. We just don't know who they are yet. There's another tumor characteristic that really makes tumors very responsive to immunotherapy, to the drugs, pembrolizumab in particular, which is, it's probably the other drugs, but Merck, the maker of pembrolizumab, looked at this first, and it's called mismatch repair deficiency and microsatellite instability high. So it's MSI high, mismatch repair deficient. That's what this means. And these tumors that have these tumor types tend to respond well to immunotherapy. So this is just a distribution of the frequency, the percentage of mismatch of tumors with mismatch repair deficiency or or that are microsatellite and unstable. And so if you look, the endometrial cancer has about 10% in late stage. So they've got overall like an 18% incidence. It's not very frequent in any type of cancer. And then if you see thyroid cancer, where I just missed it, early stage thyroid cancer, we're at about 2%, but that is some. So that there are thyroid cancers that do have microsatellite instability or mismatch repair deficiency. And what the study with pembrolizumab showed was that they looked at patients with microsatellite instability or mismatch repair deficiency and treated them with pembrolizumab. And 46% of the patients of these different tumor types, any type of tumor, had their cancer shrink. So now pembrolizumab Keytruda is approved for tumors that are microsatellite unstable or mismatch repair deficient. So regardless of the cancer type, so you could have sarcoma with this, thyroid cancer with this, prostate cancer, even though pembrolizumab isn't approved for thyroid cancer, if your tumor has this characteristic, then you can be treated on label with, insurance will pay for pembrolizumab. Pembrolizumab is also approved for tumors that have a high tumor mutation burden. And what that means is that it's not really anything you need to know what it means, but it's called TMBH, tumor mutation burden high, which is at least 10 mutations per megabyte. You don't really need to know that. But you can see here, this is Caris. This is the molecular testing company that I use for my patients and that we use at Georgetown. And they've done a lot of really great work. They do a lot of research as well with this information. And thyroid cancer, under 10%, but what is that? Maybe 8%. And this is just thyroid cancer, are TMB high. So if the tumor's TMB high when you analyze it via Caris or Foundation Medicine or whatever the platform is, then you can be treated with pembrolizumab on label. I think anaplastic has a slightly higher incidence. So just over 10% of those cancers are TMB high. So for the cancers that are TMB high, pembrolizumab also has a good enough response that that now any TMB high tumor can be treated with pembrolizumab. So this is the published data of the overall response by tumor type that is TMB high. So small cell lung cancer that's TMB high, they had 34 patients, they had a 29% response rate. Endometrial cancer, TMB high, 47% response rate. Thyroid cancer, they don't report the response rate, but both of the responses were complete responses. So the tumors disappeared completely. I don't know what kind of thyroid cancer they were, but if the tumor is TMB high, at least based on this little study, you have a high chance of response and you can get the drug via insurance.
Dr.
Yeah.
Gramza, we have a question regarding how do we measure, how is PD-L1, PD-1, as well as MSI, TMB, how are those things measured?
That's a really good question. So what you can do is, I put it down here, you can have your tumors. So PD-L1, most pathology departments at least at universities, but even like if the path is sent to LabCorp, they can do PD-L1. So PD-L1 staining is pretty standard. Why is that? Because lung cancers, colon cancers, most cancers nowadays are need to be stained for PD-L1 to get the treatment options available. So your regular, tumor in the paraffin block that's sitting, in the lab somewhere can be stained for PD-L1. MSI high tumor mutation burden. So MSI high, I think there are some regular pathology labs that do it, but you can also just have it all done if you have your tumor sent to a place like Foundation Medicine or Caris for complete molecular profiling. I think, some of you may have had your tumors sent or, heard of these, to check for the BRAF mutation, for a RET mutation or NTRK fusion. But what they can also do, and what may have also already been done, you just might not know the results, is they can test for mismatch repair deficiency, MSI status, and the PD-L1. And that's pretty standard, at least with Caris and Foundation. I don't have as much experience with the others. So you get your tumor tissue that's been either get a new biopsy and have it sent, or they can do the archive tissue as well. So I'll just read you my last slide, which is just to conclude that immunotherapy can produce durable anti-tumor responses in some patients with cancer. And, the number of immunotherapy agents that are in investigation are just increasing. I mean, the slide that I had from 5 years ago with all of the immunotherapy and cancers that they treated, it's 5 slides now. So I didn't put it in there. I just gave you that one little one. The lenvatinib and pembrolizumab combination has high response rates and long-lasting remissions in poorly differentiated thyroid cancer and anaplastic thyroid cancer. So, that really might change our practice for these patients, but that's to be determined. Pembrolizumab is FDA approved for any cancer where the tumors are mismatch, repair deficient, microsatellite unstable, or tumor mutation burden high. We see really good responses, and you can have your tumors tested.
Wonderful. Thank you, Dr. Gramza. I found it personally so interesting and relevant. Thank you so much.
Yeah, and I'll just tell you, there are so many other, there are immunotherapy combination studies, and some of them do allow enrollment of thyroid cancer or all solid tumors. So, there are a lot of clinical trials out there and lots of exciting things that are happening that are just a little beyond where we are now.
That's
Sorry,
great.
go ahead.
Let's, we have a first question, and I was taking steroids and they help with my energy level and dysphagia. My doctor recommended I stop taking them because they react negatively with Keytruda and reduce the effectiveness. Do you have any thoughts on this?
So the recommendation and for clinical trials, usually you're allowed to be on a clinical trial as long as you're taking less than 10 milligrams of prednisone a day. So a low dose steroid is probably not going to affect the efficacy of Keytruda. We don't think that the low dose steroids do. Anything that's strong enough to, like a higher dose, that's really going to suppress your immune system. You give the lower doses, that just helps with inflammation, overall, swelling maybe, but the higher doses are what you need to, put the brakes on the immune system. And that's what we give to treat side effects from immunotherapy. So yes, that could make the immunotherapy less effective, but a lower dose, no.
The next question, thank you, doctor. If the tumor removed is over 12 years old and the patient has been on multiple TKIs as cancer mets slowly grew, should a new biopsy be done for TMB and MSI high? Current mets are in lungs and pleura. Is that very invasive?
Yeah.
And there's a little more question.
Oh,
and
sure.
The patient was sequenced at select MSKCC study. I don't know if this was done.
So if you
over
were
6 years ago?
over 6 years ago, trying to think, because I do have patients who have had so couple things. I'm not sure what test the select at Sloan Kettering, that the select panel is running now in comparison to 6 years ago. I would guess that if it was done 6 years ago, they did not test for PD-L1 or MSI high or mismatch repair deficiency. And that, also, I think if the last biopsy was, if the tumor tissue is 12 years old and you've had multiple treatments, we would always recommend another biopsy, because you could have developed, new mutations, and you could have a new targetable mutation, or you could have, high mutation burden, or mismatch repair deficiency or something like that. So then to the other question about the pleura and the lung biopsy, it really depends on the location of the lung nodules or the pleural nodules. Sometimes it can be pretty non-invasive. Sometimes they can go in via bronchoscopy. If you have a good pulmonologist, they can go in and do biopsies. Sometimes they can just do a CT guided biopsy. So if the tumors are sort of close to the outside, like the pleura, if there's a nodule on the pleura, they can go in and get a biopsy that way. And the testing doesn't really require a huge amount of tissue, really 1 or 2 core biopsies, like with an 18 gauge needle, not an FNA like you would have for the thyroid or a lymph node, but a core biopsy. Couple core biopsies are usually enough for this testing.
Thank you, Doctor. I hope to get to all these questions. So one
Sure.
question asked is, any thoughts or comments on CAR T therapy for which trials are about to start?
Yes, I mean, CAR T therapy is extremely effective in some cancers, and that's certainly engineering. That's complicated, where your immune cells are engineered to attack your thyroid cancer. And I would say, if you have thyroid cancer that's refractory to all therapies, and if that trial, and if it's metastatic, if you're relatively healthy otherwise, that I would certainly encourage participation.
Thank you. Which patients are the best candidates for immunotherapy? If you have stable disease, is it worth trying?
Probably not. I mean, I think if the disease is stable and you're tolerating your therapy, or you're not on therapy, I would leave well enough alone. Even though I told you that most patients don't have severe side effects and most patients tolerate it well, there is a chance of severe side effect. I mean, every time I'm working in the hospital at Georgetown, rounding on the inpatients, we have someone in there with immunotherapy mediated something, whether it be pneumonitis and they have trouble breathing, or colitis with the diarrhea, or hepatitis. It's rare, but it can happen. So if things are stable, I would probably just hold off until progression, just because even though side effects are rare, it's possible.
Wise advice. Can you address immunotherapy for anaplastic thyroid cancer patients with the BRAF mutation?
I don't think we really know. So, I mean, first of all, I guess it depends. If you've had your testing done and you have one of these, you can certainly, if you progress on BRAF therapy, certainly trying immunotherapy after would be a great idea. We don't know what the combination does in anaplastic thyroid cancer. In my mind, it's just another option. So if you had any indication that you could be treated with immunotherapy, I would probably try. I would try if it were my patient and they had the BRAF mutation and progressed on dabrafenib and trametinib, I would try to get lenvatinib and pembrolizumab and see how the response went. I mean, because at that point, you really don't have a lot of great options. And based on this data, I would definitely try it.
Next question. We have two more questions. What immunotherapy combination would you try for Hürthle cell cancer? Thank you.
Good question. So for Hürthle cell, there's no, so right now, technically you would do lenvatinib or sorafenib, and then if the patient's progressed, then we now have second line cabozantinib. So that said, there is some data, small amount of data that that it might work better in Hürthle cell. So if the patient had like microsatellite high or mismatch repair deficiency or TMB high, I might try pembrolizumab since it's FDA approved. I don't know if I would give the combination. I might stop the lenvatinib and try the immunotherapy by itself, because it would be nice, to get a patient off of lenvatinib. So I would probably just do immunotherapy alone.
Thank you, Doctor. You have a hello from I believe a patient, Mike and Lisa, and thanking you again for being here at ThyCa. We all thank you, and they look forward to seeing you at their next appointment. We have one more question, and if any questions have not been answered, you can again in the chat section see the address to direct those questions to Dr. Gramza. Can you speak to the use of Keytruda when a tumor has been fully removed and there are no distant spread, but a small number of lymph nodes were positive?
So that's adjuvant therapy, I think, is what you're asking about. So when there's no evidence of cancer present, sometimes in some other cancers, you give immunotherapy to prevent the cancer from coming back. We don't have any data for that in thyroid cancer. So unless there's cancer that's measurable, growing, and meets these criteria, we wouldn't give that Keytruda.
I have one more question, and it's, do you know of any patients who have tried Pembro with, I believe he's saying dabrafenib. If not, please correct me, but Pembro and dabrafenib.
I don't. I have not read or heard of that. So that would be the BRAF, inhibiting the BRAF mutation. In melanoma, it's interesting. So what they do in melanoma, they used to give, melanoma has a high rate of BRAF mutations like papillary thyroid cancer. And what they used to do is give BRAF inhibitors first, BRAF and MEK inhibitors, so dabrafenib and trametinib first. And then if they progress, they would get immunotherapy. Now they give immunotherapy first, and then dabrafenib and trametinib. So who knows what's going to happen in thyroid cancer? I mean, I think that we really need to have more studies, and it's hard because the numbers are so small.
Okay. We have one more question, one more minute. Would you be able to answer?
Oh, yeah.
Is there less efficacy with Tylenol and Keytruda?
No. So Tylenol is acetaminophen. That's an antipyretic and does not affect the immune system. It just lowers your fevers and reduces pain.
Thank you, Dr. Gramza. We all really appreciate your information. Doctor, we really appreciate your your presentation. I do. In a personal note also, we've had great success with pembrolizumab and in anaplastic thyroid cancer. So great presentation. Thank you.
Yeah, I have 2 patients who I've treated well, one 6 years ago, we just stopped her pembrolizumab. I think she's cured of her anaplastic, and I have another one who I'm treating right now.
Oh, I love the word
So
cure in anaplastic thyroid cancer. Thank you. And in the same
I
breath.
do too. I do too.
Thank you so much, doctor.
Hi,
And
everyone.
with
Thanks
that,
for
we're going to,
attending.